level you have that you or aim to have in the meeting, in the chat, that would be great, because we do try to take some degree of attendance loosely in this meeting. And I will start as a precedent, but maybe I will not be the first one. Here we go. Welcome, Pat, listening in. We're glad you're here. All right, it's 4:03. We have a big agenda, Asha. And so I'm going to get started. Again, welcome everybody to the reconvening of the Gravity Terminology public call. My name is Sarah DeSilvi. We have had a summer holiday and we're just getting back started with our fall 2026 domains. We will be covering access to primary care and hot off the presses, concepts in disability access and disability justice after a recent meeting with our subject matter experts. Next slide. We are very, very glad you're here. And we just want to make sure that you all are aware that everything that we do in this space is publicly posted and publicly available on our Confluence after the meeting. You can find the slides there and the recording of the meeting. We do try to have an active seminar format. This is a fairly formal seeming in its slide presentation, but informal gathering. And even though we follow a formal process. So please send chats to everybody. We do try to integrate thoughts as we're going forward. We have a guest speaker today. So we might have you hold questions until the end there, unless she acknowledges them. But in general, we do try to make sure that we have established understanding in keeping in common when we go forward. Next slide. We are bound as an HL7 project to follow the HL7 antitrust policies as stated in the operating manual of HL7. So professional associations such as HL7, which bring together competing entities, are subject to strict scrutiny under applicable antitrust laws. And so any entity participating in any way in HL7 meetings have a responsibility of following the HL7 antitrust guidelines and understanding them. Next slide. It's also a key part of being accredited by the American National Standards Institute. Whew. Our agenda today is as follows. Welcome. We've done some serious welcoming, but we're going to keep on welcoming some announcements, including a new work group. We're going to briefly go into an overview, but 7 years in now, Mark, it's been 7 years. Mark was here at the way, way, way beginning. We kind of are trying to not, restate things that might be inherent, but for anyone new, in the appendix at the end of the presentation and available on the Confluence after are all kind of overview materials about Gravity. And then always on the Confluence is also available an overview deck. So we're trying to streamline our overview presentations and our public meetings 7 years in, but there's always material available for review. We're then going to go into a fall 2026 domain level set. And then we're going to be going into, our first couplet or triplet. It's a set of concepts, which is concepts in disability access and disability justice. This is recently rescoped. We had intended or initially scoped it to just focus on physical and communication access, but at the advice of our SMEs, we're taking it up a level, thinking about general concepts in disability access and disability justice. And then we'll make sure that we address those specific concepts of physical disabilities and communication access as we go. We'll then segue into access to primary care and then close with community homework and next steps. We are incredibly grateful within our disability access and disability justice section to have one of our subject matter experts, the amazing Megan Morris, here to present and kind of ground that agenda item. Next slide. Okay, next slide. So our announcements get bigger. Gravity is always doing stuff. So the technical work stream, as some of you may know, meets Wednesdays 1 to 2 Eastern Standard Time. It's nearly pens down on the ST 3.0 with intent to publish later on this summer. Herculean work done with the community across 2025 and 2026 on that Standard for Trial Use 3.0. The implementation workstream just met last week and will meet next in person at the Civitas conference. Civitas is our member, sponsor, and lead for implementation workstream. And given that the intended meeting date of the implementation workstream was the same week of the conference, we decided to just meet in person there. We're going to have a Thursday breakfast session at the conference, and we hope to see you. Register for the conference. There's a lot of gravity-aligned presentations there. The whole Tuesday is almost completely gravity topics. So not completely, in every session, there's something related to gravity. So we look forward to seeing you all there. We also have a new service. We have a new work group, which is so exciting. So it used to be we just had these three base public meetings. We had terminology, tech, and implementation. We had to create a whole new work group to kind of focus on the unique actors, experts, and use cases and purposes and community regarding topics in service navigation and provision. So this meeting just kicked off last week and we'll meet next week. It is a cross workstream member-led initiative that develops consensus deliverables to support navigation, connection, and enrollment in services. There's two core projects of that meeting. The open classification of services for the purposes of navigation and connection to services, which just published its version 2. 4 years in. And then a new project called the Service Eligibility Code Taxonomy, which is a member-led initiative to develop codable concepts to represent the features of patients, people, households that get matched with programs to establish eligibility. There's information about both of those projects on the Confluence. I'm not going to go too far into it here, but please do explore. Please come and meet us next Tuesday, 12 to 1 Eastern Standard Time, and we look forward to doing that work with all of you. And then this is terminology. Next slide. All right, updates. This was all part of the focus of our implementation meeting last week. We do try to ensure that things that are happening in the Gravity ecosystem, we update our community about. So in 2024, Gravity worked with the American Health Information Management Association and the American Medical Association on our coding guidance for the Accountable Health Communities Health-Related Social Needs Screening Tool. With the understanding that although that it's really difficult to have all of the careful analysis of dimensions that go into our terminology development be implementable and implemented. And so we have created coding guidance in the past for the AHC HRSN. We now have an updated version of the AHC HRSN with updates from our utility and security domain. And we also have additional resource guidance on 3 valid open use instruments within that same section as well. So we have the Hunger Vital Sign updates and implementation guidance, the Housing Stability Vital Sign, and the newly validated Transportation Security Index, or TSI-3. So those are our base 3 domains. And again, Mark was here in 2019. So housing, food insecurity, and transportation security. There are now 3 instruments, new in some ways, and we have new implementation guidance to support them. Lucy?
Hi, Sarah and everybody.
Hi.
On this Hunger Vital Sign, Housing Stability Sign trademark, what's this trademark about? Who owns those terms?
Children's Health Watch, the publisher. So often validated instruments are trademarked or copyrighted in some way. So the name Hunger Vital Sign is the trademark. The use is open use. Same thing with Housing Stability Vital Sign. The name Housing Stability Vital Sign is trademarked, so nobody else can use it. But the instrument's open use. Transportation Security Index is Creative Commons.
So nobody has to pay.
Nope.
Okay, you just have to acknowledge with the TM sign. Thank you. Okay.
Yep.
Thanks.
Yeah. Any other questions on this page? Lucy always asks good questions. In February, there will be additional LOINC updates on some like interpretation guidance of some of the USDA six-item food security module and the abbreviated child and adult food security scale, and we'll be publishing guidance for those as well when that's released in February. But anyway, these are pretty lovely implementation tools, and we're really excited about the TSI-3. We've been working with the Transportation Security Lab at University of Michigan, Dr. Murphy and her team for years, Sarah, as they validated down from the very large scale to the brief TSI-3, and it's very exciting. Oh, okay. Yes. Uh, wasn't prepared to talk about that today, but maybe if we have time at the end, we can have a little policy sesh. Okay.
And
Um,
Sarah, it may be for another meeting
or
too.
maybe just you and me and then everybody together. Yeah. Okay. Love it. Next slide. We have we're not going to go into any questions on announcements, and I have a it's been a long day. I have a brief gravity terminology overview, and then I'm going to pass the mic to the amazing Dr. Morris. Okay, next slide. Okay, so Gravity is a collaborative initiative with the goal to develop consensus-driven data standards to support the collection, use, and exchange of data to address the social determinants of health. Next slide. Our amazing friends and sponsors are listed here. Gravity is a group project, right? We have entities coming in to support us financially. We have experts coming in to support us with representation and governance. We couldn't do anything without all of these amazing members, so very grateful for them. Also, of course, acknowledging our in-kind support from CMS, which helps support our technical work stream, and Civitas, who of course leads our implementation work stream. Next slide. This is again, I feel like Mark, like it's homework. So in 2019, we recognized that as we addressed the risk of being invisible, we'll talk more about that in a second, this injustice of not having the data we needed. We acknowledged the risk of developing data and wanted to make sure that we created a set of guiding principles to ground our work. This infuses everything we do, everything from standards development to standards implementation, to standards curation, to standards maintenance. These 6 principles are fundamental. We keep them in line of sight at all times. We have the principle of improving personal health outcomes, improving population health equity, ensuring personal control, designing appropriate solutions, ensuring accountability, and significantly preventing, reducing, and remediating harm. And those of you who have come to the meeting often know that sometimes that last principle, when applied, means we do not develop concepts, right? Because we do not trust, we don't feel like the ecosystem is ready to responsibly curate and implement them. And so we choose to not develop codable concepts or even not include existing concepts in our value sets, right? So the curation part is very significant there as well. Next slide. And I was mentioning data justice. So as we are doing this work, the principles, a very near and dear model to me is Lynette Taylor's model of data justice, which talks about the justice of invisibility and visibility, engagement and disengagement, and the ever constant principle of anti-discrimination. And again, we try to keep all of these things in mind as we're doing our work. This actually centered very significantly in our racism domain a year ago, in our incarceration status domain a couple years ago. And so we keep this in mind as well. Next slide. This is our new model. Mark, I don't know if you've seen this. So when we started in 2019, we had 4 core activities that we thought of as central to our work, and I don't even think, and Mark, you can come, you were there. I think we called it our conceptual model without ever actually discussing whether it was, right? It appeared, and we said, this is our conceptual model, and it was that circle, Mark, of the screening, diagnoses, goals, and interventions. Our members, our community, our evolution, our social care friends have all asked us to interrogate that not even the concepts, but also the directionality of it, the idea that these things happen in cycles and you always start with screening and you always go to this. Absolutely. Patricia, this is on our Confluence. It's a final artifact. It can be spread wherever you wish. And so part of what we did in STU 3.0 was we had ballot comments on finally addressing the problems with that model. I want to note the Social Care Voice Co-Design Initiative that we did in 2024 also asked us to account for that model. And so we updated it. We didn't call it a conceptual model anymore because it's actually not a conceptual model because we don't address workflows, right? We build standards agnostic to workflows, actors, and it's the highest level. We know that in any domain, these activities might be different, but across domain, cross use case idea representation of what we do, this was the intent of this model revision. And so we have 4 areas of activities: assessment of social conditions and context, interventions and service delivery, social and clinical care coordination, and ever critically measuring and reporting toward those outcomes, that were part of our principles. And within assessment of social conditions and context, we have comprehensive assessment. Patricia, this is the NASW standards of practice in healthcare settings, the social worker comprehensive assessment. Yes, Mark?
I can wait till you finish. I just
Okay.
have a question about it.
We have social condition determination, which is a critical shift because it's not just about social risks. It has to include protective factors as well. We have identifying goals of care, and we have utilization of standard instruments and observation methods. And that is elevated from screening instruments because in 2026, the instruments are not only used for screening, some are used for comprehensive understanding and evaluation. And we don't just use instruments like questionnaires anymore. We also, when we're doing community domains, are making observations based on different types of data. So assessment of social conditions and context has been updated across the board to reflect where we are in 2026. Is now your question, Mark, or should I keep on
Sure.
going?
No, this
Okay.
is I know that we have more recently been taking on looking as well at community level domains,
Yeah.
not just individual level domains.
Mhm.
This is the first time that I'm seeing this. It reads a little as focused on the individual level of care, and I'm
It was
wondering if there's a
intended to be broad, right? So we did interrogate it from that lens, and the comprehensive assessment, all of the topics, some of the topics, when relevant, are very person-centered, like shared care planning. That's a person-centered activity, right? But when we have developed use cases for community level data and community level interventions, we interrogated whether the model was capable of representing them. And we kind of felt like it was, but we're always open to ideas. Like,
okay.
yeah, I mean, like it's a first attempt. And if you have any thoughts, just submit a JIRA.
Will do.
Okay. That's
Sarah?
the biggest, yeah. Hi, Lucy.
Just to follow up on that, this is also the first time that I've seen this.
Oh, you commented on it.
I did.
Yeah.
Too much going on. Okay. Referral to social services.
Mhm.
Is that a better idea than referral to community-based organizations, CBOs?
Yes, because not all social services are community-based organizations. This
And
is a
not all
glossary update.
CBOs are social services.
Exactly. I know.
Okay,
I know.
okay.
I know. We did some work in 2026. We updated our glossary, and so I went so nerdy deep in trying to
Okay.
understand the different, and social services is the most agnostic concept we could find, given that WIC Mark is a lawyer, right? Community-based organizations usually by principle have a community governance model, community engagement, all these layers of what it means to have that title. A WIC office does not align, right?
Oh, okay.
I know. Yeah, so we're using social services right now for that highest level concept, but again, we'll figure it out.
So you also have faith-based organizations
Exactly.
providing that they may be actually nonprofits under the law, but they're not usually thought of as CBOs.
Exactly. So we did, yes, again, interrogating whether the concept we were using was fit for purpose. And CBO, even though we use it extensively throughout our IG, was not. And so we are using, so CBO stayed in version 3.0, and we're going to be doing some updating in 3.1 because once we did the glossary, we realized there was a lot of work to do. And Megan, I said I would not go to 4:30, and here we are. We're going to go to 4:30. Okay. But Lucy, did that answer your question?
Yes, it does. And I'm just going to make a very eccentric comment
Okay.
that referral and service provision, I understand 1,000%. Authorization, I have certainly learned about. I would say that payment for services
Okay.
is not within Gravity's scope of work. If
Well,
people want to get paid, that is a whole layer of social services that has been debated for 100 years, and it started out unpaid and now it is. And so I'm just going to comment that authorization in here for the Gravity Project model is fine, but I would say that payment for services is outside our scope of work. Thank you.
unfortunately, it is though. I love you, Lucy. Because remember the payment and reporting discovery? Maybe. I love you. Members have identified the payment and reporting as pretty critical, and there's a social
Yes,
service
I know.
report. Yeah,
Of course they would do that. And this is an appropriate platform
I
for
love
them to voice that, but
I
that
hear
doesn't
you.
mean, okay,
Okay. Okay, I hear where I get it. Okay.
okay, moving
Okay,
right
got it.
along.
Okay. Anyway, well, this will come back more. But and then the big thing too is not just the payment part, which is new, but outcome centered. Our third use case has always been aggregating and analyzing data for the purposes of policy and structural changes. That's always been our North Star, in line with the World Health Organization conceptual framework for action on the social determinants of health. Right. So we put outcomes as the fundamental basis of everything at the bottom there. Okay. It is around, it's on the Confluence, we'll interrogate it, but it's a huge step forward for what we had, which didn't represent the complexity of what we do at all. And you're going to see echoes of what we had in some terminology slides later. Next slide. And this is our roadmap for 2026. SU 3.0 was the goal for tech, and we're here in access to primary care and we haven't updated it yet. It doesn't have our disability access roadmap title. We'll fix that in a second. There's a massive thunderstorm coming through right now. I'm going to go off camera just because I anticipate Vermont will not be able to support my bandwidth with this with the severe thunderstorm warnings I'm getting. Okay, next slide. Any questions on that? And we're very, very close. I'm going to try to get through the terminology section in time for 4:30 start for the next domain. Mark?
I'm curious if there are any updates to the reference implementation for API access. So for those that don't have Fire servers, again, this may be a question that's better folded into the future, but the work of trying to make sure that social services, CBOs, and so forth can also participate has been important to me, important to what I explained to policymakers, and knowing if there's any updates like STU 3.0 is considerably further along. I'm curious about the reference implementation. Thank you.
Corey's on the call. It might be a tech work stream question. Do you have an answer there, bud?
Yeah, we are keeping the reference implementations up to date. I think we're just about to publish STU3, so that's a bit of a moving target, but we will do a fast follow to update the reference implementations to STU3.
Good to know. Thank you so much.
All right, so brief overview of the terminology workstream, trying to keep our merry band on target. Okay, next slide. This is us. Was the access to Oh, no, so we haven't even gotten into the domain work yet, Hannah. You're right on time. We're going to start the domain work at 4:30 with disability concepts, and then go at primary healthcare access at 5 o'clock. So this is us. I'm not going to spend time on this because we have to get to Megan. Very, very grateful for these amazing women of the Gravity Terminology team. Our beautiful team. I know. We're so lucky. Next slide. Very, very grateful for the support of Registry Foundation and Registry who have been supporting our work through 2024 to 2027. The aim was to make significant advances in social risk terminology, and we really are doing that. The steady pace of our 3 domains a cycle that we've been able to do since 2024 is just, a massive step forward. So very, very grateful. Next slide. This is where we are again. So you can see some updates here. So we work on developing US CDI for supporting data standards to address social determinants of health across standardized instruments and methods, conditions, and mark there you can see social risks and protective factors. Patient-centered goals, and I should say here, Mark, community and patient-centered goals. There you go. Update noted. Sarah B. and Asha will figure that out. Interventions and outcomes. Next slide. This is our process that we are all kicking off together. So the Gravity terminology curation process, on the next slide, you can see our terminology paper was published finally in, heck, we can go back one little slide just for a bit. We'll go more on that in the next slide, but we follow this process. It is very rigorous by now. So there's 2 months of pre-work, which is gathering subject matter experts and gathering the literature. We then do our public phase of the work, which is identifying, reviewing, and then voting on the artifacts that we've identified with our subject matter experts. And then the submissions team goes into analyzing and submitting the terminology concepts. And again, it's always grounded in data justice and social justice concepts. We always try to ensure we align with federal and community social care taxonomies. In these domains, you will also see us aligning with other work in the standard space because there is some harmonization to do. But this is the science of what we do. Next slide. And you can see we did publish it in the Gravity Project Social Terms of Health Terminology Lifecycle paper. I've been very excited to hear the different countries which have been picking up this paper and adopting it in their own use. The Joint Initiative Council is Joint Initiative Committee is kicking off an international analysis of social terms of health data standards, and it's been fun to see who's using this paper. Next slide. Okay, 429, we're doing great. This is the last vestige of the model that was. And if you see these 4 circles, you can see this is what we had before we had the model that we were all discussing prior. So back in the day, it only included assessment instruments, diagnoses, goals, and interventions. And you can see why we had to break it out. And you can see those the arrows indicating a process that when we actually examined it, the process wasn't universal, as no process is. Most processes aren't. So we had to undo it. And essentially in this work, what we'll be doing is identifying the standard instruments used to name the domain and standardized methods, identifying diagnoses or conditions or findings that matter, identify person or community-centered goals or organizational goals that relate to the risk or condition, and then figuring out all the things that we do. Next slide. It blooms into something like this, right? The new part is up in the top left up there is our work in service type classification that we are doing in the Service Navigation Provision Work Group. But this is how those questions, what instruments do I need? What diagnoses are critical for the domain of reference? What are the goals and what are the interventions? This is how that comes to bear. And this is a fraction, of course, for those of you who know gravity of everything that is included in our value sets. Next slide. And as I just breadcrumb, the final artifact of the work we will do is not just the terminology, but how we curate it in value sets that are expert curated, consensus grounded, and part of really the final public accessible way to engage in our work. I should have updated this slide, and my apologies. All those program value sets that program concepts we submitted a long time ago, and there's no pending March SNOMED release. They were released, and there is a new program value set in VSAC, and it's fantastic. And we'll update this for next time. All right, next slide. Whoop, whoop, here we are. Kickoff. Access to primary care, disability access kickoff. We are so excited. This is our many month endeavor, our journey towards 11/19 when we vote on everything that we have identified. I have the honor now, next slide, of passing the mic, 432. Oh, and fall domain level set. Let's circle back around, Asha. And Megan, are you okay for time if I take 2 more minutes?
Oh, absolutely. Yeah.
Okay. I thought I was ready. I have like a few more slides. Next slide. You have to bear with me a little bit longer. So our fall 2026 domains are always grouped. Every domain set we group with intention because we want our SMEs to have crosstalk. It was so wise that we did it in this instance because 2 of our SME groups have actually merged into one. So this is a good thing. So we will be addressing access to primary care and concepts in disability access and disability justice. We're going to touch upon both communication access and physical disability, but just today, we met with our subject matter experts. They helped us understand that we really don't want to we want to take it up a level and think about it comprehensively and focus on the use cases of communication access and physical disability, but we don't want to leave anything out. Other relevant domains are many. We have covered topics in healthcare access. We have covered topics in language access. Our community food access and access to nature domains covered accommodation. And our domain of mistreatment of non-elder vulnerable adults fundamentally delved into functioning and capacity and topics in disability. So we have been thinking of some of the concepts within this domain for some time, and it's our honor to finally focus on them. Next slide. I just want to name that in our domains, and Mark, this is thinking of you. So whenever we address access, there's always 2 vantage points we think from. Does the person or patient or self receive the relevant access to nature, health materials, food markets, insurance, right? And also, does the community or organization objectively offer access in a way that is not only present, but present in a way that meets the person within the standards of quality and accommodation? And this came up in health literacy, I think was the first time we started to think about this, like many, many years ago. Our lovely friend Gerardo asked us to think about that, and it came up again every single domain since. And we'll be thinking through similar lenses this fall. I just want you all to remember, what I've said might seem, abstract, but if we remember Usher from Food Access, next slide. This was the model of access that we thought of with Usher, right? It's interesting, Asha, the amazing Asha has done a lot of lit review, and these topics of access come through regardless of the domain, and our SMEs will help us understand. But again, this is one you've all seen before because it came through with community food access area. And in that, we discussed accommodation. And I think one more slide and then we're almost done. Just noting, we thought, we looked to find the amazing RWJ graphic that they updated a bit ago. And just noting the difference between equality and equity in the work that we do and always aiming up for equity. Next slide. And I think now I can go to the amazing Megan. Megan, it's our honor. Next slide. Introduce you. I'm going to skip to you now. This is your intro. We are so looking forward to your presentation. The amazing Dr. Megan Moritz from NYU Langone talk to level set in the why of disability access and disability justice. Megan, over to you.
Great. Thank you. So when Sarah and the team asked me just to do a bit of intro and a kickoff of why this matters, why disability, I generally start these conversations with my story and my family story. So next slide. So this is my uncle, David, with his parents, my grandparents, at his high school graduation. David was born with an intellectual and developmental disability, and that included seizures throughout his life. And because of his seizures, he was often falling, injuring himself. He spent a lot of time in the healthcare setting. And so what that meant growing up is I had a front row seat to seeing how the healthcare system really treats and interacts with folks with disabilities. And I've had the privilege of sharing stories from his life and unfortunately his death in a few different venues. I'll tell one story though today is once David had a seizure and fell and hit his head, and he was admitted to the hospital, had a brain bleed, and he was having difficulty breathing, so they put in a trach to help him breathe. And I was away at the time, and I came to the hospital about 3 days later. And when I walked in the room, I was surprised to find David strapped to his hospital bed with his arms tied to each side, and had no way to contact a nurse, no way to communicate. And David, before he had been admitted, he was an active social guy. He loved walking the neighborhood, catching up on all the neighborhood gossip. He monitored the length of everyone's grass. He was very social. And so the fact that he didn't have any way to communicate was alarming to me. So I went to the nurse's station and said, "Can you tell me what's going on here?" And the nurse looked at me confused and said, "Well, you know, he has a developmental disability, and, he can't communicate. Why would we need to give him access to a nurse call light to let us know?" And I said, and then she also expressed concern that he, because of a disability, might be dangerous and might pull out the cords and tubes and such. And I said, "Let's go back to the room." And so with his restraints, I said, "David, put your left hand is yes, your right hand is no." And I asked him a series of questions, and he was fully alert. He knew the date, he knew who the president was, all these details. And so he had been stuck in that bed for, at this point, 3 days, strapped down and no way to communicate. And it was really based off of, why did that happen? There was lots of things that went wrong. First off, there was just assumptions about David and his diagnosis and who he was and what he could and could not do, including his communication access. And this, again, stories like this really led me to, and experiences like this really led me to think about how can we improve the healthcare setting? How can we make it more accessible and accommodating for folks with all types of disabilities? And that has led us to do a number of studies around documentation of disability status. And I'll get to that in a little bit. So next slide. So just some level setting is the estimates are about 27% of adults in national surveys report a disability. So that is actually a pretty significant number or proportion of our population. So next slide. And we could spend hours talking about the literature that demonstrating the health and healthcare disparities experienced by folks with disabilities. I provided a few examples here. So folks with physical or intellectual and developmental disabilities are approximately 3 times more likely to have diabetes or heart disease as compared to those without disabilities. In the most recent COVID-19 pandemic, the number 2 predictor of mortality from COVID-19 was having an intellectual and developmental disability. Number 1 was age, but again, number 2 was intellectual and developmental disabilities, and they were 6 times more likely to die from COVID-19 than folks without disabilities. Moving on to more of the healthcare setting, we find, in the literature that women with disabilities have particularly those with cognitive or physical disabilities, have significantly lower rates of cancer screening, such as mammograms and pap smears, due to reasons such as lack of accessible diagnostic equipment, as well as assumptions and biases from the healthcare team. Next, my next example is folks with communication disabilities. 1 in 3 report difficulty finding a provider who is willing to see them. And then finally, for folks with communication disabilities, including hearing loss, they're 3 times more likely to experience a preventable adverse medical event in the hospital when hospitalized. Next slide. So historically in medicine, we have thought of, when we talked about these disparities, you say, well, of course, they have a disability. That disability is what leads to poor health and healthcare outcomes. But next slide. See if my animation works. Oh, sorry, it's missing some bit, but I'll describe what is supposed to be on the slide. It's should be no surprise to this group. It's disability plus a whole host of different social and environmental factors, including social determinants of health that are really negatively impacting the health and healthcare outcomes of folks with disabilities. Next slide. All right. I liked this model. It's old, and the unequal treatment disparity model from the was IOM, now National Academy of Medicine. And I've always really liked this graph, in particular, talking about disability and disparities. Is that so? You see on the left-hand side, you have a bar graph, and that y-axis could be any sort of health or healthcare outcome, and you have your non-minority and your minority bars there, and you see a difference between their outcomes. And what this model says is this difference can be attributed to 3 different factors. So first is clinical appropriateness and need, and patient preferences. And again, historically, differences in care have been, well, of course it has to be different because they have a disability. And so that has been really the focus of those differences. And what that does is it really ignores and minimizes the effect of these 2 other factors. So first, the operations of the healthcare system and the legal and regulatory climate, as well as discrimination, biases, prejudice, stereotype, and uncertainty in healthcare. And really, it's those last 2 factors or sections that really make up disparities. And so that is a lot of the work that myself and others on this call do, is really thinking about how do we address those factors to improve the health and healthcare of people with disabilities. Lucy, yes.
That last box is really interesting, and I'm wondering whether liability fits in here. Providers not accepting or poorly treating certain kinds of patients because they will say there's a liability issue here.
Yeah, that's a great question. And there was a national survey that was published about 5 years ago it was a survey of practicing physicians across the country, and there was a associated qualitative study, and they actually asked these physicians about caring for patients with disabilities. And in particular, in the qualitative paper, the title of the qualitative paper is "I'm Not the Doctor for You." And the clinicians would talk about all the strategies they would use to try to not take on patients onto their caseload. And really the reasons they cited were, we didn't hear a whole lot about liability. It was more of, they cost more. I don't think I have the right training to care for them. We also hear a lot of just negative attitudes about, and again, it goes to that biases, is that people with disabilities are faking their disabilities. They're trying to get government benefits, and that's why they're coming to me, and I just don't want to deal with that. So we see attitudes like that. And so, yeah.
Thank
Again,
you.
we could spend a lot of
Thanks.
time on that. Yeah, thanks for the question, Lucy. Next slide. So there are, it's interesting, kind of compared to other other kind of groups. It's interesting. We do have these actual legal requirements up for healthcare organizations to provide equitable or equal access to care, going all the way back to the Rehab Act of 1973, which is over 50 years old. And then The ADA in 1990 was most sweeping, and then we have provisions in the Affordable Care Act as well. Next slide. So these laws really, what they require is equal access to care through 1, modifications of policies, practices, and procedures, 2, accessible facilities, and 3, effective communication. And on the right here is really sort of a model of kind of how we're seeing organizations implement this. So first off, I just want to center this around folks with disabilities. They need to be foundational to any work that we're doing. But how do we move forward? How do healthcare organizations move forward to not just meeting these laws, but think about people with disabilities as experiencing gaps in quality and safety? So how can they improve the outcomes of their patients? And fundamental to this is documenting disability status and accommodation needs, having systems and processes to provide accommodations that, again, are federally required under these multiple laws, having accessible environments, both physical and virtual, and then improving our interactions and effective communication. And then you see there in the middle, we put disability coordinator. It's really interesting. Section 1557 of the Affordable Care Act requires every organization with 15 or more employees to designate someone to be a disability coordinator. And this is a really unique position. And I think this, in that they are sort of poised to really be the leaders in their organizations to implement these initiatives, including thinking about documenting disability status and accommodation needs. Next slide. Unfortunately, though, for those disability coordinators and really healthcare organizations generally, there's not a whole lot of resources and supports of how to implement this. And so a few years back, we started what's called the Disability Equity Collaborative. And this is our website. Next slide. And we had multiple work groups. We have a research work group. We have a work group on guidelines for implementing accessible care. We also have a work group on documentation of disability status. And then lastly, our kind of call it our foundational work group is our leaders work group. And we have a learning collaborative, about 50 health systems from across the country that meet twice a month. And it's an opportunity for them to share ideas and support each other and share challenges they're experiencing, and learn from each other. And these are, again, those disability coordinators who are working in health systems. Next slide. So out of our all of our work groups, but in particular our standards and guidelines work group, we recently released, and it's on our website, a implementation guide for health systems and clinics and healthcare teams on how to implement accessible care. So we've released 4 different chapters: 1 on building a disability accessibility program, 2 documenting disability status and accommodation needs, 3 providing accommodations, and 4 effective communication. We should be, by the end of this year, releasing 1 on medical diagnostic equipment, accessible physical spaces and structures, and lastly, wayfinding. But these 4 chapters plus some general resources, it's almost 300 pages of resources on our website. It's pretty extensive. Yes. Next slide. And I think that is, I was trying to be brief. Hopefully that gave you just a little bit of a taste of, again, why this population is important and sort of a lay of the land of what needs to happen to improve the accessibility of healthcare and some resources that we've developed. So thank you.
That was amazing, Megan. Thank you so much. We're so lucky to have you with us. Any questions for the wonderful Dr. Morris? I have to say, your use of storytelling to ground what we did is so powerful. And we often, something we haven't said is yet this session is it's really about telling critical stories, right? That's what we aim to do. And in telling them, make sure that we don't put people at risk, right? But, thank you for grounding us in that story, and really honored that others shared their stories too, Joe. Thank you for mentioning your own story, and Patricia for, anyway, thank you so much. Any questions for her before we segue?
Megan, are you the only person like you in America? Or there are
No.
people like you in other hospital systems?
Um, there are not. There are definitely other people. I am not alone. Unfortunately, though, I would say there's just not a whole lot of us doing this
Yeah.
work, and part of it is, um, disability has been under-recognized as thinking about it as a disparity population. For example, it wasn't until 2023 that the NIH designated disability as a disparity population. Um, so it's been hard to do research. I'm a researcher at heart, and that's my daytime job. But yes, I mean, and it's a large population. Again, a quarter of over a quarter of the US population. And so there's just a lot of work to be done. And yeah, unfortunately, not as many of us as there should or we would hope, but it's definitely an increasing recognition. So yeah. And
Well,
I'll
I hope
just,
your
oh,
participating here
yeah,
is going to turn out to infiltrate other people, other sectors, other realms, other everything about what you do. Because I will just say for myself, a lot of this is news, and I'm really looking forward to learning a lot. So thank you.
great. Thank you, Lucy.
Think
And
has a question.
yeah, our friend Trish.
Well, it isn't a question. It's a shout out to Megan. And I just wanted to make sure like that everyone on the call knows this. Like the DEC was really instrumental in advocating for us to be able to embed disability status into the EHR as a demographic element. So I shout out for that effort because it's just going to help improve the care and accommodations for persons who need it. And then the other thing is, while there's only one Megan, she's been able to convene that work group of hospital 88 coordinators. And I was fortunate to be able to go to one of the meeting and speak. And it's such, like to your point, Sarah, about her opening the conversation with a story, she creates such a safe space for these individuals who are working in different hospital systems around the country to be able to share what's going on, like the true realities, and they're able through that sharing mechanism, be able to help each other and really improve the lives of patients and their family members with disabilities. So just a big shout out for the work you do, Megan. I want people on the call to just know how, the rubber hits the road truly with your work and really is so impactful. So thank you again.
Yeah. Well, thank you. And I'll do one, like a little bit of a shameless plug. And just also, if you're interested in learning more, we are going to, the registration is opening next week. We'll be doing a workshop in October 1st and 2nd. And we have 19 speakers from all different healthcare organizations across the country presenting on their initiatives and the work they're doing. So happy to
Are
share
any
that.
of those people payers, Megan? I mean, I immediately leaped to, I made a comment much earlier in the meeting about being paid is not in our scope of work, but I immediately leaped to providers not now doing this, absorbing the importance of starting to do it. They're going to start saying, where are the codes to get paid for this stuff? So I'm
Yeah.
wondering whether any of your October speakers are actually payers or health systems that are now paid per member per month, who might well have an incentive to be doing this.
Great question. And we are just dipping our toe in this workshop, and we hope to expand it in future years. Right now, it's just health systems because we really wanted to highlight how to actually get this done and how people are doing it. And we have some great examples of really success stories, but also challenges they experienced. I'll tell you kind of one snippet. One of our health systems, who I would say one of the leaders in the country, in particular, they've started documenting disability across hundreds of their outpatient clinics. They have about 40 something odd hospitals a part of their network. And they recently told us that they looked at their kind of accommodation requests, and it was they were getting thousands of requests every day. And looking at the denominator, it was 25% of all of their clinical encounters was someone with a disability who had a accommodation request. So it is like there's a tidal wave of this, that's boiling up. And so how do we really meet the needs? And I just think it's such a missed opportunity for health systems to think about, like, how can we improve the quality of care for these patients I mean, this is, again, a quarter of your population is experiencing disparities. There's gaps in quality. Wouldn't it be great if we put systems in place to help decrease those gaps? And I think it would translate to improved outcomes and ultimately costs. Thanks. Janice.
Yes, thank you for this so much. I actually have an interesting story. I really appreciated your story, especially about the communication. And my father had a brain tumor when my parents were pregnant with me, and it didn't manifest fully for a couple of years. And when it did, it was seizures and others issues. And we moved across the country for him to be able to have a brain resection in 1959. It was we were going to the Mayo Clinic originally from Seattle, and we ended up going to the veterans who were doing some experimental surgery with lowering the body temperature. Anyway, so he was very disabled when he came out, but really it was a 50-50 if he'd even lived through the surgery. And he ended up learning how to walk and talk, actually, learning how to re-speak with me, and learning my alphabet about the same time. So I grew up with this. He passed away when I was 9. I went into the field of special education, and we started one of the first programs for independency in the nation. Actually sold our program to Boston in 1981, I think 82. And the people in this group home that we had were high functioning individuals, with a few who had just gotten out of institutions who were not necessarily high functioning. And because it was deinstitutionalized, period then. And they bought a motel, and we had like 16 individuals, and we worked with them to either go to school, work, whatever, closely. And we were a very tight-knit team. And we also went to our capital, and we passed the first wheelchair access bill in the nation. I always like to talk about it because it was. And so it was wheelchair access, and then for government and school buildings. And so that was a precursor, that was 1981, or actually 79 to 80 is when we went down there. It was called Handicapped Congress, which would be unheard of now, but in the time that was what it was. And so I worked in that area for quite a while, and I just really applaud you. And having, as a child, I had a non-communicative father in a hospital bed in the home, and I fully understand. And as an older adult now, so many of my friends and their children need accommodations, and the stories go on. And I appreciate, your mentioning of 24-25% for accommodation. It really is. And I feel a lot of the major health systems, what I've seen, are doing a pretty good job, but a lot of it falls on the states and accountability. And also it's at an individual level. But no matter what, the parents, the person themselves, or whoever, has to advocate for themselves, because there's so many gaps in so many places. So thank you so much for this. I look forward to participating with you.
Great. Thanks, Janet. Mark?
Thanks so much, Megan. I wanted to go back to the mention about payments and the possibility of special codes, and it raises for me sort of the strategic question about whether having special codes, does that telegraph that we are not expecting the same level of high quality care for everybody? Like, you would think that there's a way in which we say you're caring for all people. The code should be the same for all people. The level of care and the variation within what's required to meet that level of care ought to be the same. I don't think it's a black and, I don't think it's either or. I think there's probably some places where there's some adjustment, but I just wanted to throw out that strategic question because it has downstream ramifications. Thanks.
Yeah. Thanks, Mark.
Thank you so.
You know, Mark, that reminds me of debates long ago about whether when doing quality of care studies, whether you adjust for race or not. It's really analogous. We can't adjust for race because we don't want to be racist. Well, you have to adjust for race, otherwise their special problems are not going to show up. So let's talk about this sometime. It's a really, to me, it's a really naughty question. Thank you.
There certainly are ways to describe, like, it makes me think about the 2019, the way the American Medical Association updated their E&M coding guidelines a little bit ago to really kind of think broadly about what complexity is, right? So it used to be that medical complexity had a very narrow lens. And then with the update, they're like, actually, complexity is social conditions, environmental context, like, accommodations. Like, there's a lot of things that go into like to thinking about and so in that sense, it allowed this like contextual, understanding of like what it takes to take care of people well. And it makes me think about that, Mark, because from like a holistic perspective, there are many factors that go into meeting people's needs. And from a payment perspective, AMA did try to say it's way more complicated than we said a while ago. We want people to be able to think broadly and thoughtfully. And that was the first step in there. And that was the first time, again, they put social perspectives and environmental factors in that. They're like, you're allowed to think about, like, to account for the fact that the patient's food security was part of what took you, and how to address their diabetes within that was part of why it took so long, or was so hard. But luckily, we have Megan and our other Angeles here too for like 4 months. Aren't we lucky? Is it 4 months? Something like that. August, September, October. Yeah, about. Okay. I'm gonna keep us going. I'm the taskmaster, and I'm not a very good one. Next slide. I think we have two. Oh, did we not include the slide on Pasio or no?
Yes.
We took it. We
Uh-huh.
didn't. Just noting that from oh, there it is. Oh, okay. Um, oh yeah, we already covered that part. Great. Next slide. Oh, was this after? Did I miss this?
Yes. But it's all good. We can circle right back.
Okay. What do you mean? Did I not say this? Or
Well, we went to Megan.
okay, I didn't miss it. We skipped over it, and I'm just okay. Fantastic. I was like I am like who knows? I I could have, but I just want to note for the sake of that there's two different areas we're looking at aligned standards, and so Trish, our amazing friend from Passio, we just want to note that we are bringing HL7 relevant work groups for concepts that overlap into this space. And so just, part of our due diligence is not to build over other standards or disrupt them, but to harmonize and integrate with them. So very grateful, Trish is always here, which we love. But James Patterson and other friends from Posse are going to be coming here as well, just to make sure that we all harmonize. And here's my call in. Trish, I wrote you in here to ICF and just making sure that we think about it as we go forward. All right, now, next slide. We're going to be, for those of you, that was our disability access level set. And now I'm going to pass the mic to my amazing friend, Asha, to kick us off on access to primary care.
All right. Well, good afternoon, everyone. It's great to be back and talking with you all. So we're going to talk about access to primary care. And what does that mean and why does it actually matter? So we want to level set on access because this definition does a lot of work downstream. And access to primary care sits at two levels, and both have to hold for a person to actually get care. So the first is the individual level access, the person's connection to care. Does this person have regular primary care provider? Is there an established relationship, a place where they can go, someone who knows them for continuity's sake? And the question here is simply, does the person have a way in? That's it. The second is community or system level access and the system's capacity to serve. Is there enough primary care capacity in this area for people to actually obtain care? Are there enough clinicians, enough appointments, enough hours? The question here is there enough care to go around for everybody? So access is the fit between those two levels. A person can be insured, motivated, and ready, and still have no access if there's no capacity where they live, right? And a community can have capacity that a particular person can't reach. So when access breaks, we locate the problem in the system and not the person. And that framing is deliberate and it will carry through every concept that we build in this domain. And just to note, this works rests on Sarman's 2016 work, building on Pinchansky and Thomas's from 1981, and it aligns with Healthy People 2030 and their objective for increasing primary care access. Okay, so why does it matter? Why does it matter to standardize in this domain? So there's two reasons. First, primary care is the part of the system with the strongest evidence behind it. Starfield's work is the anchor here, and health systems built on strong primary care produce better outcomes at lower cost with smaller disparities. And when primary care holds, everything downstream works better. The second part is that we're losing it. So between 2002 and 2015, the share of US adults with the usual source of primary care fell from 77% to 75%. That might sound small, but it isn't. It's millions of people. And the decline was not distributed evenly, as most things aren't. It fell fastest among younger adults, uninsured adults, and racial and ethnic minority Americans. The people with the least margin lost the most ground, y'all. And this is before the impact of the current legislation that has not even taken effect. So the gaps are not random, they're structural, and they show up in ways that we will be building terminology around. And one of them is the shortage geographies that HRSA already designates, the health professional shortage areas, the medically underserved areas, the maternity care target areas. I live in a state where half the counties in our state don't have access to maternity care. These are places in this country where capacity just simply isn't there. And that's a system property, and it's already measured by HRSA. Another one are the disparities by race, ethnicity, and disability status that Megan so eloquently shared with us already. And these persist after you account for insurance and income. So this is not reducible to coverage simply. And of course, discrimination itself suppresses care. People who've experienced discriminatory treatment in a clinical setting delay care, they avoid care, they disengage from the relationships they'd otherwise maintain. So the system's behavior shapes a person's connection to it, which brings us back to the previous slide. Each of these three sit in the system side fit. And that's the reason why the framing really matters here. So moving on again to why it matters, the literature tells us why primary care access and continuity really matter. So two findings. The first is access to primary care and continuity within it contribute to lower mortality and lower morbidity. More primary care providers per capita leads to longer life expectancy, full stop. It does. The second finding is structural continuity creates an accountable provider relationship. Someone is on the hook for this person's outcome over time. And that continuity of care is associated with lower mortality. But what's interesting here is the mechanism points to accumulated knowledge. A clinician who knows a patient's history, values, fears, they outperform on an equally qualified clinician who doesn't. So that accumulation of knowledge really, really matters. And so why does that matter beyond the exam room? It's because it's the foundation of the entire payment architecture that it's built on. The patient-centered medical home, the CMMI innovation method models, the ACO Reach, the ACO Primary Flex, AHEAD, the relationship and the measures the provider that measures the provider on the health of the entire panel. So the individual relationship leads to a population outcome. And that's really the bridge from clinical evidence to policy infrastructure. So what are the use cases here? At the individual level, remember, is there a way for this person in? Some of those use cases are emergency care and inpatient care discharge care planning, the no wrong door social service to primary care navigation, including 1115 waiver models, the health insurance navigation through Affordable Care Act, and population health management activities. I was a population health management nurse for over almost 5 years, and a lot of what we did was support our primary care physicians in their HEDIS measures for their panels. At the system level, again, this is about, is there enough care to go around? The use case there is the shortage area designation and capacity planning. So all of this is operationalized in regulation through Community Health Center mission of HRSA and the Indian Health Service. So that is a really fast, down and dirty level set on primary care access. I'm going to open it up for any questions. Mark?
Thank you so much, Asha. Can we go back to slide 59 for a sec, which was the model slide? And as a civil rights litigator, I wrestle with this, and don't take this as a comment about the model. It's sharing some experience for whatever it's worth. I often see even in the effort to take us to an electronic health information system, the use of access and availability to say we've done it. You see this in other areas too, like telecommunications. We can reach 99% of people with our telephone system, and that's the message, but that doesn't mean that 99% are using it.
Right.
And it's that use component that I have in my advocacy that I have tried to tag on to access. I've always said access and use, access and use. It's enough to say that you've got the access, but is it being used? Because if it's not, there's probably an access problem. And access is often measured at the system level, which tends to hide what the problems are at the individual level. So when HHS is often said, is the provider or the payer providing the access without really knowing what's happening on the individual level? And even then, is it access with special effort or access without special effort, which was the terminology from the Cures Act? I just wanted to throw that out there as it's definitely a set of thoughts in my mind as I look at the language in the model. It's not a disagreement or anything like that. It's just me always thinking about how to apply something. Thank you.
I hear you. Thank you for saying that. And I am going to see if we can go back. Oh, no, we did that. So yes, access, there are dimensions of access. And what I hear you saying, one thing that I think about a lot in my maternal health equity work that I do is the acceptability factor for access. You can have access, but if it's not acceptable to you, do you really have access? And when I say acceptable, I mean you're experiencing discrimination when you go for care. So, yes, we will be exploring all of the dimensions of access in this work.
Asha, I think this is partly why we pulled in the difference between having a primary care provider and topics and continuity, Mark, because they're different things, right? So simply having a person in the PCP slot in a administration detail in a ER does not mean you are engaged and have a continuous relationship with them, right? And they have very different outcomes and research aligned with them. And so we did try to separate those variables out from the get-go. And then another thing, a lot of what, whether it be a CMS model, the NCQ, PCMH model, they look at engagement too, right? And that's where the acceptable comes in. Like just because you have someone doesn't mean they're the right one, or it's the right location, or it's the right type. Like sometimes people have access in my health service area, rural, Joe is talking about Wyoming. I'm like frontier Vermont for one more week. So sad. But like sometimes we have to move individuals from private physician-led practices to the FQ because they had access of a sort, but it actually was too expensive. So we had to shift them from one model to another, right? Or they had access in that, in one clinic that didn't have the resources for complex needs that a different person did. So we did bring in that continuity factor with that in mind. And of course, the fun thing is when you look at the access literature and the access models, and this is, again, Asha and I were nerding out about this. Well, I was nerding out and like barraging poor Asha with it. Is the same concepts get utilized from, whether it be community food access or nature, we just saw Usher up there. They get repeated across different domains with different facets, and we look forward to exploring that with you all, both in relevance to the primary care access domain, but also to disability access as well.
Indeed.
Lucy.
Yeah, this is a wonderful approach to primary care. Do you have any? How do you experience it? Is the system responsive? Much of the work that we have done, dare I say all of it, and Sarah will remind me that I'm forgetting something, but much of our work ends up as codes in an individual patient record.
Mm-hmm.
How will community level access, finding, and standards end up in an individual patient record? And what will be its meaning if it goes there?
Well, Lucy, this is actually really helpful because we did talk about the same thing when we did community food access. Like, how is community food access relevant in a patient record? So I right now, Sarah DeSilvi, in my clinic, work in a pretty diverse area in my HSA. So in the southern end of my health service area, we have fairly good access. I mean, like we're not we're on the border of a more populous county, so we are better than the area just north, along the Canadian border. I have no transparency on that data, even though we have the data from HRSA that tells us clearly where we are in the healthcare provider shortage area. It's not in my health record. It's somewhere else. That would be really helpful for me to understand how HSPAs and maternal care access are actually affecting the place where my person lives so that I can appropriately care, plan, and organize. Same thing for community food access. I can say, you need to eat better, right? But that's not very helpful if they live in an area that doesn't have good community food access. They don't have markets with fresh fruits and vegetables. So we imagine a future where at least the codable concepts, which are fairly stable, like sometimes, codable concepts for communities are very volatile, like AQI, Air Quality Index, changes hour to hour, right? But things like this, they're fairly stable. So we can imagine those community level observations or findings being within records to help individuals get better care through having the care team understand the place where they live. And also, I think the problem at SARM is going off. Any clinic draws people from different places, right? So if I can understand by the place of residence, the unique community features of where they live, compared to my other patient who comes from a different place. That's all important. And it's information at the community level we don't have access to in personal records. It's also, of course, important from a health systems perspective. It's the heart of community health needs assessments, population planning. It's everything. It's everything that happens in that area. Sorry, Lucy, you just got me to, does all that make sense? I went off.
Yes, I'm very happy always to hear you up on your high horse. So I would just comment that information about community system level access for all of the domains that you just mentioned, Sarah, the source is not the patient. So this is going to
Oh, yeah.
be a message to
Exactly.
somebody
Yeah.
to start designing EHRs and
Yeah, to
start.
pull in this information that's already, yeah, we do, agreed.
So we should be clear. I just think maybe we should be explicit that we're addressing a domain now where the patient is not the source of the information. The provider needs information that should potentially be readily available in the record somewhere in your clinic. You should be able to hit a button on your computer that tells you everything that you just said you would be helpful to know for care planning.
Yeah, that's a lovely, and some records do that. Like my record pulls in the AQI because I live so close, the air quality index, so I can understand how it's affecting my COPD patients or asthmatic patients for the day. But thank you, Lucy. And we tried to briefly touch upon that in the level set slide. Asha, we talked about patient respondents and community observations, but we'll clarify that better. And we look for it. And the great thing is this data exists. I mean, like HRSA does the analysis for us. It's not like it's that hard, right? And we should be able to pull it in. So agreed. I'm so Lucy's always like, I'm going to poke the Sarah Bear, and then she's going to say a lot of things. All right, I think we're good. I think that was the end. So community homework, and then Mark, I think we have time for me to I just wanted to double check on USC 7. So if we go, I know I mean, it looks like who's here? 19, only 3 people have left. That's pretty amazing for 520 okay, we are so grateful you all are here. We are so grateful Megan had that lovely presentation and kicked us off in our disability access and disability justice work. Thank you, Asha, for your careful research and presentation on primary care access. Your homework is to review and catch up, and submit concepts that you feel like are relevant for this work, and you can send them to gravityprojecthl7.org. To read, if we send materials for reading, you can come and read the concepts. If you want to, all the papers we try to, send along the lit. It's grounding our work. And then I will use next slide is the meetings, which there are 4 meetings. So terminology, tech, implementation, and service navigation provision. And now I'm going to briefly do a teaser on USC 7, Mark. Because I just had to remind myself that it didn't change from what we talked about in this reading. Just a reminder that what ONC said with their full chest when asked about it at the ONC annual meeting last year, right? How did moving social conditions and problems under problems generically and losing a specific call out, how did it affect requirements to document it? And did it seem to demote it, right? Their answer, whether it's true or not, was that as a example, it is assumed to be normative. And so now it's even more certain that you must be able to represent. And so for problems that's like such as food insecurity, right? So you have to represent problems. And as Hannah, always here, every other Thursday, 4 to 5:30. We can't wait to have you back. We will be doing this work every other Thursday until November 19th. Come on back,
Thank
friend.
you. Thank
Yeah,
you.
of course. I know. And then we're following that, we do a lot of brainstorming and then it kind of settles down and we're thinking about instruments, diagnoses, goals, interventions, both from the person and community level. Okay. But Mark, that was what they said, right? And it hasn't changed because it didn't budge. But they were adamant that they actually, Sarah Armisen said, and with our full chest, ONC is stating that these things are so important, they're now moved to be not a theory, but a normative example. And this is why we're stating them as examples underneath the problem area. It was like they got elevated in their perspective. I know, but whereas individual is and I have statements about that. Okay, but where it is called individually is where there are contextual groupings of things within USDI in assessments. So we're still called out there because all different types of assessments are called out there. But where it could move under, it is. And then we still are testing. We submitted our protective factors domain, and that's still in thinking, and we're going to be submitting a new USCDI concept for programs. Mark, programs, now that we have those program concepts. So again, bring me the program list. That's my dream. I want it with all my heart. But nothing has changed. It's literally the same as it was in February.
As an illustration, Sarah, let's take maybe goals as an SDOH
Yeah.
goals as an example.
Yeah.
And it's now under goals generally.
Mm-hmm.
Is the sorting within the data element, does SDOH goals become a sort of a subset, but a subset that is held together
Mm-hmm.
under goals, or is it sort of sorted through alphabetically? So,
No,
you
it's
know,
still
as an example, with everything else, so that its collectivity is lost.
the second follow-up question to that was we said, how does this change US core? Right? We asked, how does it change? And do we still curate special value sets and instructions for social determinants of health within the aligned US core elements? And ONC said yes. Maintain special call-in groupings. You've already done the work. Why disrupt it now? It's exactly what it needs to do. So keep it. Yeah. So that's it's not getting lost in the sea of everything else. And so the references within US core were supposed to stay the same.
Okay.
Sarah, I hope you
Good.
memorialized everything that you just said in response to Mark in a letter back to ONC so that as we discover that so we can investigate whether this actually plays out as they expect, anticipate, and wish, even though they have de-emphasized.
Yeah, so I will, it is memorialized in multiple different ways.
Okay, in writing, in writing.
In writing, in a letter. We submitted a letter and our comment is there. We actually asked it to stay. Gravity did, right? As an individual call in our members. So I did that. I submitted a letter for USCDI for that. But thank you, friends. This was a great meeting. We missed you all. It is so nice to be back with the collective. We will see you in 2 weeks where we continue to address these concepts, and we are so grateful. Whoop, whoop.
Thank you.
Thank you. Take care.